Greetings, everyone. My name is Vernon Sondak. I'm the chair of the Department of Cutaneous Oncology, and I want to welcome you on behalf of my colleagues to our Moffitt Discovery Series, today focused on an insider's look at melanoma and skin cancer research. Today we're focusing specifically on some research in melanoma that the Cutaneous Department has been working on in two different arenas related to the treatment of patients with melanoma. So I'm going to be joined today by my colleagues, Keiran Smalley, who is the director of the Melanoma and Skin Cancer Center of Research Excellence, and one of my surgical colleagues, Matt Perez, who is another melanoma surgeon along with me in the Department of Cutaneous Oncology. Go ahead and go to the next slide. We've got a large number of people. We know a few are still going to be joining us, and we're really excited to talk to you today. But of course, with every presentation like this comes a few disclosures and disclaimers, and very important, this isn't intended to be medical advice for any specific individual, so viewers should consult their physicians, any of us in Cutaneous, or whoever your doctor is right now, if you have any questions. Don't rely on information contained in this presentation for immediate or urgent medical needs. And if you think you have an emergency, call your doctor, go to the ER, or call 911. Never disregard professional advice or delay seeking care because of information you find on this webinar or on the internet or for any other reason. Good advice. Next slide. We also have our disclosures of the industry partners that we work with, and you're going to hear about some of the results of that collaboration. So we disclose it, but we're also quite proud of the work that we're doing with a number of different partners of all types to help us advance the care of melanoma patients. And next slide, and that is in fact what I'm going to start talking about is one of those collaborations. But first, I always start with background about melanoma, a reminder to people of just how commonplace melanoma has become, unfortunately. Over 200,000 new cases of melanoma and over 8,000 deaths are predicted to occur this year, 2025. It's coming to a close pretty quickly. Over 10,000 cases in Florida. Florida has the second most cases of melanoma of any state after California, which has a slight increase in the number of melanoma cases, but has almost twice as many people. And Moffitt is the biggest center in Florida and absolutely one of the 2 or 3 biggest centers in the country for taking care of melanoma cases and doing melanoma research. And that's what we're going to be talking about today. Next slide. Okay, now, a lot of times when people think about research, they're thinking about a laboratory, test tubes, maybe little laboratory mice. And yes, we do a lot of that, and you're going to hear about some of that today from Dr. Smalley. But a lot of the research that we do is focused on how can we improve actual treatment right here in our cutaneous clinic. And it starts with saying, what is the standard? What can we do to improve it? So we've been focused on what we can do to improve the treatment of all types of melanoma, the common types and the rare types. And we're going to talk about both what we do for the common cases and some of what we do for the rare cases. What's the standard treatment of a melanoma that comes to us in a localized way? What does that mean? It means no sign just when the person comes into the clinic that the melanoma has spread. to the lymph nodes or beyond. Much of the time, we can make that determination just by examining the patient. We don't need a lot of tests, but we certainly have scans, ultrasounds, and other tests that we can do when there's any question about whether a melanoma is localized or spread. Once we've decided it's localized, the first step in treatment is a wider removal that we call a wide excision of the primary melanoma. That's standard in all cases. Why? Because almost always there's a little more to the cancer than meets the eye, and the biopsy in the dermatologist's office isn't enough. But the next step for many patients is a sentinel lymph node biopsy. I bet there's probably quite a few people in our audience who've had a sentinel node biopsy. It's one of the most common surgeries we do. I did 3 already today. It's indicated for otherwise healthy patients who can have general anesthesia without anticipated problems, and their melanoma is at least 0.8 millimeters thick when measured under the microscope. Wherever it is on the body, we can track the lymph nodes that are connected to that piece of skin and find those sentinel nodes. Why do we do it? Patients with a positive sentinel node are followed more closely, almost always get more scans and tests to look for possible reoccurrence or spread of their melanoma, and sometimes even receive post-operative adjuvant treatment, we call it, preventative treatment designed to proactively decrease the risk of the cancer reoccurring. Next slide. That's the standard. We're trying to improve the standard through research, collaborative research, improving the patient selection for sentinel node biopsy. What do I mean by that? I mean, we do a lot of sentinel node biopsies, and a lot of times they're negative. That's great news. We're always happy to tell a patient, good news, your nodes are negative. But we also know that that person might say, well, gee, then couldn't we have figured that out without doing surgery on my lymph nodes and leave it in place? It's a great question. Patients have been asking us since the dawn of sentinel node biopsy. Can we identify patients whose risk of having a positive sentinel node is so low they could have avoided having that surgical procedure? Next slide. To address this, we have to understand why we do it and what are some technologies that could help us figure out who those people might be that could avoid the sentinel node biopsy. In the red box here, I've focused on who do we think about and why do we recommend sentinel node biopsy. When the melanoma is very thin, the chance of it spreading to the lymph nodes is extremely low, 1, 2, maybe 3%. And so our guidelines are based on that thickness of the tumor because it's the strongest known predictor of the likelihood we'll find a positive sentinel node. When the melanoma hits that magic 0.8 millimeter threshold, the number goes up above 5%, and that's when we say, for a 5% chance that there's cancer in there, we're usually going to consider a sentinel node biopsy. Around the country, around the world, once it gets to a millimeter, everyone says we shouldn't even consider it. We should just do it. So there's a bit of a gray zone in that 8.8 to 1 millimeter group, that 5 to 10% chance, and that's going to be a very important part of today's story. Next slide. Again, if you've got 5% chance of having a positive node, you got a 95% chance of having a negative node. How do we figure it out? Can we? So we conducted a large national study. So new, it was just published last month, less than a month ago, October 22nd, the study that Moffitt led called the Merlin 001 study. It was a study to look at gene expression profile testing to predict who might have a sentinel node that was positive, who would have a node that was negative. Next slide. This prospective multi-center test that we started with people that we didn't know anything about what their sentinel node was going to show. As soon as they came in to the clinic, they signed up for this study. Maybe some of you signed that form when you were with us. And a small piece of their tumor that was already biopsied, a small piece of the biopsy that was already done, was sent off for this special gene expression profile test to determine if this test could predict who was at such low risk that they didn't need a sentinel node biopsy. Next slide. This is how the test works. The gene expression profile actually measures how 8 different genes that are related to the growth of melanoma, and the more the gives us a sense of how aggressive and how likely the melanoma is potentially to spread to the lymph nodes. But it's also linked up with 2 other features: the age of the person and the thickness. So the 8 genes tell us something, but also the thickness of the tumor, the age of the patient, it's all factored in. And at the end, what comes out of the computer is either it's low risk or high risk. Not an exact number out of this test, just this is how it is looking. Our goal in the study was to say, so what's that low risk really mean? Is low risk low enough? Or where is a low risk test, and how does it vary for different people of different age, different thickness, etc.? Next slide. This was a very large study, the largest study of any kind of molecular or genomic test ever done in melanoma. We took over 2,000 patients from 9 study sites. Moffitt was one of the largest sites with over 350 patients from Moffitt on that study. And this gene expression profile test was successful almost 98% of the time, not 100%, but pretty darn good, leaving us with a total of 1,761 patients who'd had the sentinel node biopsy and the gene expression profile test. And neither the surgeons nor the laboratory people nor the patients knew what the result was. That's why we call it a blinded study. Nobody was charged for this. The company that we partnered with did all these tests free of charge. And then after the fact, we put it to the test and said, all right, could you pick how did the low risk and high risk results do? Next slide. Let's see the answer. First of all, the characteristics. I throw this in here because in the second half of today's presentation, we're going to talk about one specific, very special kind of melanoma. That's the one highlighted in red, acral lentiginous melanoma. This study was an all-comers. Anyone who would have a sentinel node biopsy, we took them all. Head and neck, trunk, arms, legs. The acral melanomas are on the extremity, your hands and your feet. And as you see here, it was only 2% of all the melanomas in this study. So it's a rare subtype. You're going to hear a lot about it because we do a lot of work with that and every other one of these types of melanoma. But this test tested all of them, this study. Next. Here we get to the bottom line, as it were. For the entire study group, all 1,761 patients, 17.6% had a positive sentinel node. Okay, that's about 1 out of every 6 or so. That's a very good number, means we were selecting our patients properly. The test was definitely able to split groups into a higher and lower risk group. The low risk patients was 37% of the entire group, 7% positive lymph node rate. The high risk group, which was a little more frequent, 24%. That's a big difference, more than 3 times more likely if you were high risk than low risk. But it didn't get so low that we could say, oh, no more sentinel node biopsy anymore until you've had this test. These are still, those numbers, even for the low risk, if you take all comers, still too high to abandon the test right now, at least based on our modern criteria. Next slide. So we looked into this a little bit more. We had previously, before we even started, we hypothesized, we speculated that there would be 2 groups that this might be particularly useful for. The earlier stage melanomas, which we call stage 1B, that's the earliest stage at which sentinel node biopsy is used, and the older population. Why? Because older patients have a little bit more risk of general anesthesia. They have a little bit more chance of complications from the operation. These might be, and they have maybe fewer years to benefit from the results of the treatment. So we previously speculated these might be the 2 groups to really focus on. And in both cases, these were large groups. Over 1,000 stage 1Bs is in the top half of this slide. And you see that the stage 1B overall rate was 12.5%. It went down to 6.5% if you were low risk, but it was 18% if you're high risk. Very similar for the older patients. Almost half of the people on the study were over 65, and overall 14.5% positive, but only 6.6% if they were low risk, much more if they were high risk. Next slide. Is that enough? How do we use this? Well, what we can conclude is that this test clearly could give us a hint of who was less than a 10% risk, but it didn't get below that magic 5% threshold. It absolutely discriminated, with a high risk result having a 3 times higher risk of having a positive node. And so what we've concluded, and what we're doing now today based on this research, is looking for people in which maybe a 5% threshold is too strenuous, too many negatives for that individual patient. And in that case, this is a test that we can now do, commercially available, takes about 2 weeks to get the result, and use it to help make a decision about whether or not to go forward with a sentinel node. So this was a large research study, took years to complete, and it was done with a really, really high standard of scientific rigor. We're really excited about that. Not many companies would put their test to such a strenuous evaluation for fear it might not come out as good as they wanted it to. But we were able to conclude this, and I think in the years to come, we're going to see this information be useful. Hopefully the test will get better and better and better as we go along, as we continue to study this. But we wanted to present it to everyone here, and in the question and answer session, get some kinds of feedback about what people think of this kind of research, how they think about even things like when would I want to have a sentinel node biopsy? What is the right threshold? So a lot of questions that come out of research like this, and we're just getting started. So that's the end of part 1. I want to make sure that we have lots of time for part 2, which is to focus on the other side of the melanoma research coin. You can can try to do a very big study in a lot of patients that is very generalizable, or you can study a very, very rare form of melanoma and make some progress in a situation where there aren't many centers that see enough patients to make progress both clinically and research. We're excited to tell you about some research with these acral melanomas. And we're going to turn to Matt Perez to tell us what is an acral melanoma, how is it different than a regular one, and then Dr. Smalley will tell us about his research efforts as well. Thanks again for joining us.
Great. Thank you, Dr. Sondak. And I'd like to echo, what he said. We're really excited to have this turnout today and to talk to you guys about, what we're doing here at Moffitt, and certainly what my part will be to discuss some of the unique characteristics of a rare subtype of melanoma, acral melanoma, as he described, which, we certainly see a lot at Moffitt. We see a lot of all melanoma at Moffitt in the state, but especially when these rare subtypes of melanoma are diagnosed in the community, it's almost a for sure referral to our center, in our expertise to take care of these patients. So we see quite a bit of these rare subtypes that don't always seem so rare at a center like Moffitt. Next slide, please. So acral melanoma accounts for only about 3% of all melanoma worldwide. So you can imagine there's actually even more rare subtypes of melanoma, but it is one of the rare subtypes. And so there's not a whole lot of experience outside of high volume cancer centers like at a place like Moffitt. Not much experience elsewhere for these types of patients. This disease arises in the acral or the non-hair bearing skin of the usually palms of the hands, soles of the feet, or even as you can see in the image here within nail units of the fingers and toes. And these areas, oftentimes lack the sunlight and the ultraviolet exposure that we typically see with some of the more conventional subtypes and more common subtypes of melanoma. And these tumors behave differently than those. I think it's important to note that not all melanoma on the skin of the hands and the feet are acral lentiginous melanoma, because certainly you can have sun-induced melanoma on the skin there, but it's certainly more common in those areas, especially the areas where the sun doesn't shine as much, that when you develop melanoma in those areas, it's the acral lentiginous subtype. And when the pathologists look under a microscope at a biopsy, they can tell the kind of the classic, under the microscope histology features that are unique to this particular subtype of melanoma. It's the most common type of melanoma in the patients of Asian, Hispanic or Latin American, and African descent. It's actually, if you look at all races, it's evenly distributed among the races. It's just if you are a patient with kind of darker skin, as mentioned there, if you do develop melanoma, it's more likely to be an acral melanoma than a kind of the more common subtypes of melanoma. So, we see it oftentimes in patients in Asia and Latin American and African descent. Next slide, please. There's certainly some unique characteristics of the disease other than just the kind of the unique biology of it. The anatomic location oftentimes can lead to a difficult biopsy and diagnosis. Oftentimes people are not expecting melanoma, including the dermatologist. They're not expecting melanoma in these areas. And so oftentimes these areas can be thought to be something else, and there may be, a quote unquote delay in diagnosis. And it's easy in hindsight always to, when we see patients, to think, oh man, I can't believe it took so long, to get this diagnosis. But, in actuality, these patients are, coming in with a really rare diagnosis, and, 9 out of 10, 19 out of 20 patients with that same, presentation didn't have an acral melanoma, but certainly we see the ones that ended up having those. And so the anatomical areas, there's certainly limited laxity of the skin, so tougher areas to heal, especially in the nail bed. There can be significant nail dystrophy or nail deformity from biopsy. And then certainly these are areas, your fingers, are very sensitive, right? I mean, for obvious, reasons that, for biology to understand when you're, touching something hot, right? And so you have a lot of sensory there. And so, biopsying these areas can be very, very, painful, to patients. And because of all these difficulties with biopsy, oftentimes we do see, and this has been published as well, that there's an understaging or underestimating of the tumor because the biopsy just wasn't kind of as complete of a biopsy as we would normally see in a melanoma of the skin of the forearm. These pictures on the slide are two kind of common biopsy techniques that we use for skin cancers in general. Above the top one there is a punch biopsy. It's kind of like a cookie cutter device, which will do a circular cut of a piece of tissue, full thickness in the skin, and then we'll resect that tissue and send it for pathologic analysis. The other is called a shave biopsy, and oftentimes what's called a deep scallop shave biopsy, where you kind of bend the razor blade to kind of scoop it more than and get a little bit of a deeper biopsy. These are certainly very common techniques. However, as you can imagine, doing these techniques on the nail, adjacent to the nails, on the bottom of the foot, which has a very, very thick callus, oftentimes, you may not get the full picture that you would in other areas. Next slide, please. Treatment. Dr. Sondak discussed, the treatment for, kind of all melanoma, and so that does apply to acral melanomas as well. So there's two parts to the treatment of a primary or localized melanoma. Acral melanoma, the first part is treatment of the primary lesion, where the lesion started, and making sure that you go and do a full resection of that area with the biopsy site and any residual tumor with a margin of normal tissue. The unique aspect of acral melanoma is that oftentimes, because of the anatomical, areas that these develop, this requires sometimes a partial or a distal, meaning the edge of your finger, or amputation or a partial amputation of the finger or the toe, and also complete removal. Oftentimes requires a secondary closure, meaning skin graft closure, because the limited laxity of the skin to sew it together. So you oftentimes either have to do partial amputations or skin grafts to close the wounds. And then staging of the lymph nodes with sentinel lymph node biopsy. We have seen that for acral melanoma, pound per pound, there is a little bit of an increased risk of sentinel lymph node positivity in those patients. And often with the understaging of the lesion, we have to consider if the patient didn't meet criteria for sentinel lymph node biopsy, but there's residual tumor in the nail bed or the bottom of the foot, certainly you have to consider, is it the potential of, when we do the formal excision of the melanoma, that the lesion's going to be much deeper than the biopsy showed, and therefore, we'll consider doing sentinel lymph node biopsy for even less than 0.8 millimeter melanomas if the clinical presentation is that we have a high suspicion it's a deeper lesion than what we have had so far with the biopsy. And then we perform complete lymph node dissections for the more advanced disease in the lymph nodes, the more kind of bulkier disease. Next slide, please. So unique challenges with the more advanced disease, so either metastatic disease or kind of the higher risk localized diseases. We have a lot of data, and we've made a lot of significant advancements in cutaneous melanoma through research that Moffitt's been pivotal in these large clinical trials. However, as Dr. Sondak alluded to in his slides, from that last clinical trial that we participated in, only 2% of the patients in that trial had acral lentiginous melanoma, and that's not because we try not to include those patients, and it's just because it's certainly a rare subtype. And so if it's 3% of all melanomas, it would make sense that in a general melanoma clinical trial that it is 2 to 3% of the patients in that trial. But because of this unique challenge, we often have to, and we, I mean, all kind of providers that take care of complex melanoma have to extrapolate some of the data from these other trials of more common melanoma subtypes and use that to treat some of these more rare melanoma subtypes. However, that's where I think kind of the art of medicine kind of comes into play, where you have to consider obviously what you're dealing with and understanding that kind of the unique differences and challenges with the rare subtypes and it may just lend to a little bit of a different discussion with your patients, when discussing your treatment recommendations. Generally, these are less responsive to immunotherapy. We again don't have as much data in these patients as we do with the other subtypes, but we do know that there's generally speaking less lymphocytes or immune cells that are naturally trying to attack these melanomas, and therefore have seen less of a response to immunotherapy in these patients, although they do have oftentimes good responses to immunotherapy. So it's not that we would not treat these patients with immunotherapy. It's just kind of have to consider, there's a slightly less chance of them having as good of a response than some of the other subtypes that are more sun-induced, UV-induced melanomas. And then they're less likely to harbor some of the conventional molecular targets that we have targeted therapies for, such as the BRAF mutation. And so, we don't necessarily have that mutation in those targeted therapies to lean on as additional, kind of arrows in the quiver per se. Next slide, please. So in summary, these are unique patient populations that develop acral melanoma, and they have unique risk factors. And certainly certainly the one thing I want you to take home from this is that there's the treatment challenges are given the anatomic locations and also the varying responses to systemic therapies, with these patients. And so it's really important, us as providers, when we talk about personalized care, you have to really consider that these may not behave just like the other melanomas that you kind of see more commonly. And then future directions, and I'll let Dr. Smalley, who's our director for the Skin Cancer and Melanoma Research Center of Excellence, and also somebody who in his lab has a focus on these rare melanoma subtypes, including acral melanoma. We'll discuss more, but we're hoping that we can find some kind of unique drivers and unique mutations in these melanomas that we can target for therapeutics.
All right, so thank you, Matt, for that excellent intro. So now I will focus on some of the efforts we have ongoing here in terms of research. Next slide, please. So as you heard from Matt, acral melanoma is a really rare subtype of melanoma. It actually accounts for only 2 to 3% of all melanomas. And as he mentioned, it's actually a melanoma which appears on the mostly non-sun exposed skin. So this can be the soles of the feet, the palms of the hands, and the fingernails. And again, interestingly, because it's not tied into UV exposure, the incidence of acral melanoma is exactly the same in patients whose ancestry is European, Hispanic, Asian, and African. Next slide, please. So you've already seen similar pictures to this. Here's a few examples of how this appears. So it can be either a spot which appears on your foot, or it can also be kind of like a stripe which will appear on a fingernail or a toenail. And obviously, if you have any of these signs, you should certainly have them looked at as quickly as possible. Next slide, please. So as I mentioned, acral melanomas are not caused by exposure to the sun. And because of this, they have unique features which are not the same as your regular cutaneous melanoma. The reason that sunlight is actually a risk factor for the development of melanoma, which appears on sun-exposed skin, is because exposure to the sun is causing genetic alterations in the skin that can lead to the development of melanoma. And so there's actually been a good deal of research actually comparing the melanomas which appear on sun-exposed skin and acral skin. And one of the key findings that that have been shown is that firstly, there are far less genetic alterations in acral melanoma compared to melanomas on sun-exposed skin. And then the nature of these genetic changes is not the same either. And I think it's fair to say that despite a good deal of research into this, we aren't entirely sure the underlying factor for the genomic alterations which are seen in acral melanoma. Next slide, please. So as I had said, acral melanomas have unique genomic features, and one of the things they have are these curious areas of huge genomic amplification. So to explain this simply, usually you have 2 copies of each gene. Patients who have an acral melanoma often have these regions where they can have hundreds of copies of the same gene, and it's actually a unique phenomena which is called a typhona. It's basically a typhoon of like amplification, and it's been shown that about 40% of all acral melanomas have these features of a typhona. In contrast, this feature is relatively rare in melanomas arising on sun-exposed skin. And rather curiously, the only other cancer type that has these huge areas of genomic amplification is liposarcoma. And it's not entirely clear why this is a feature shared by both acral melanoma and liposarcoma. Next slide, please. As Matt has already mentioned, another key feature about acral melanomas is there is far less immune infiltrate. This could perhaps explain why patients who have an acral melanoma are not as responsive to some of the FDA-approved immunotherapies, such as anti-PD-1. And in fact, I'm actually showing a slide of research that had been undertaken here in our lab, where we basically had carried some large-scale immune profiling out of both regular cutaneous melanoma and acral melanoma. And to basically summarize a large amount of work, we actually found there was far less infiltrate of T cells in the acral melanomas compared to cutaneous ones. Next slide, please. So I'll talk now briefly over the next few minutes about some of the ongoing research we have happening here at Moffitt into acral melanoma. Next slide, please. The first thing that we have been doing is we've been using a lot of the latest scientific and technological approaches to really interrogate the immune environment of acral melanoma. The kind of technologies we have available at the moment allow us to basically analyze each individual cell in an acral tumor. This can include the host kind of stromal cells, the tumor cells, and the immune cells. And then through these complex analytical approaches, we're able to really interrogate all these cell-cell interactions between the cancer cells and the immune cells. And the whole reason for doing these kind of analyses are to actually find unique ways of improving the immune responses in patients who have acral melanoma. Next slide, please. The other thing that we're actively involved in is trying to come up with new immunotherapy approaches for treating patients with acral melanoma. And one approach we're taking in our lab at the moment is to actually carry out engineering of T cells. And the whole thinking behind this is often The cancer cells express unique proteins on their surface, which the T cells can actually find and then come in and attack the acral cells. And so we have an ongoing project at the moment where we've been basically screening for new potential cell surface targets on the acral cells and then engineering T cells to actually come in and specifically attack these. Next slide, please. Here is an overview of some of the experiments that we've been carrying out. We basically had screened a series of acral tumors. We analyzed all of the proteins which were found on the surface, and I can tell you we found thousands and thousands of these. Our challenge in turning this into a new therapy is to find things which are uniquely expressed on the cancer cells and are not expressed on normal healthy cells. And so here on the left hand side, I've provided a list of some of our things that have come out of our screen. Next slide, please. And then after we find some of these unique targets, the next stage is to show our targets are expressed in real kind of acral tumors. And so the thing that you can see on the left-hand side here is some immunohistochemical staining. It's actually a sample from an acral tumor, and all of the staining or the color that you can see in pink is basically expression of the immune therapy target. Up here, I'm showing an experiment in which we specifically engineered the T cells to express a receptor that will attack the cell surface target. And then down here is actually an experiment showing that if you incubate the engineered T cells and the acral cells, the T cells will actually kill the acral melanoma cells. And so it's through this kind of approach that we actually come up with new immunotherapy strategies for treating these rare subtypes of melanoma. Next slide, please. And then finally, I'd like to end on a hopeful kind of a note. As you've actually heard, there's been enormous progress at treating patients who have advanced melanoma. At present, the 5-year survival rate for patients who have a stage 4 melanoma is about 35%. This is basically a huge improvement on how things had been even as recently as 2011. And because we've been so successful at pioneering new treatment strategies for treating patients with advanced melanoma, cutaneous melanoma, we're hoping to actually bring the same progress to patients who have rarer subtypes of melanoma. And I will stop there and hand over to Mark, I think.
Thank you, Dr. Smalley, and thank you, Dr. Perez, as well. Really appreciate you guys sharing this information with us this evening, and I want to thank everyone in attendance. My name's Mark Ketterer. I work for the Moffitt Foundation, and I am work in conjunction with these wonderful physicians and researchers in order to raise philanthropic funds to support the research that we have going on here at Moffitt. You can see that, we're working towards that prevention and cure of melanoma and the rarer subtypes. And that can't be done without philanthropic funding to fuel that research to that next level and get it in to the clinics and have our patients be treated in that way. So we're actually about to kick off the Q&A portion, but you can see my information on the screen if you have any interest in supporting Moffitt, or if you would like to discuss any of our research further. I'd be glad to connect you with the appropriate physicians and be able to share how philanthropy can fuel that next initiative. So I am going to start with the first question, but we'll have Dr. Smalley and Dr. Perez here to answer many of the others. But one of the questions that I'd kind of like you to kick off with, we talked about acral melanoma, and it's a little bit more of the rarer type. Why is it important to focus on these rarer types of diseases, and not just a typical, melanoma of the skin?
Well, I think the best answer for that is, at a place like Moffitt, it's because we can. We have the patient volumes in these rare subtypes where we're in a unique position to study these rare subtypes that other places, will only, hear of or read about or, see once in their practice. And so, it's a responsibility, working at a place like this um, to take on the areas that other places cannot. And these patients, while it's rare, there's plenty of patients that have these subtypes of melanoma, and we certainly want to be able to provide these breakthroughs that Dr. Smalley showed in the last decade and a half that we've had for the more UV induced more conventional subtypes. We want to bring these to all of our patients, not just the ones that we most commonly see.
Yeah, I mean, I'd like to echo uh, his comments and actually say that I think because we have been so successful in improving the treatment and the standard of care for people who have a melanoma on unexposed skin, we're interested in now using our kind of experience and our expertise to really help some of the patients who have some of these rarer subtypes of melanoma.
Well, I think we can continue down the question and answer section here. I see the first question is, I saw Moffitt was part of FDA approval for TIL therapy. Is this used often now for melanoma patients? I can take this one, as seems to be a clinical question. And so, yes, it was. Dr. Sarnaik was the PI on the trial and one of our surgical colleagues at Moffitt in the cutaneous department, and instrumental, of course, in the FDA approval for this therapy. TIL therapy is, for those of you on the call that are not familiar with it, is where you take cells that are already trying to attack the melanoma naturally in the lymphocytes of the body, and you grow them. So you basically resect a tumor, you grow those lymphocytes to a much larger number, and then reinfuse them into the patient, to basically give the patient a bigger army of these lymphocytes. It's certainly a lot more complicated than that, and it's a lot more difficult as far as not only getting the growing the cells, but also the patients are admitted. They undergo chemotherapy for lymphodepletion and everything like that. But it's been very successful. It's used as a second line therapy, so patients that are resistant to immunotherapy, and also if they have that BRAF mutation, which I had mentioned, then they need to have also received targeted therapy initially. So then the patients that are refractory to those therapies would then be potential candidates for TIL. However, it requires the patients to be have a very robust performance status, able to kind of withstand the entirety of the treatment. And so it's not for everybody, but we certainly have been pivotal in both the development of it and in the early use of it as in the standard of care setting. Is your team using AI in your research efforts? Dr. Smalley, I'll let you answer that one.
Thank you. Well, actually, yes, we are. So I'll give you a specific example because I was showing some slides earlier in which we found new potential like immunotherapy targets on the acral melanoma. And one area that we're actually using AI is to actually come up with new kind of like ways of attacking the immune therapy targets, because previously the kind of process that we would have to go through would take a long time. So you'd have to screen like hundreds of antibodies against your targets, and it would be years of work. And now there are basically programs where you can input your kind of immune therapy target of interest, and it will come up with a structure for you almost instantly that you can basically have synthesized. And so honestly, it's years of work will now be like weeks of work. And so it's really helped speed up everything.
All right, the next question is, what is the next big project you are excited about getting to patients? So I think we can both answer this one. I'll start by saying, yeah, I have an interest in using intralesional therapy. So these are therapies where you actually directly inject melanomas, and I have an interest in combining these with systemic therapies to try to make those systemic therapies more effective in these rare subtypes of melanoma. So there's quite a few intralesional therapies that are either investigational or approved for advanced melanoma, and they're even being studied very recently with combining them with systemic therapy. But I would like to use our Moffitt experience and our unique opportunity at Moffitt with these rare subtypes to see if we can make these kind of more traditionally, quote unquote, cold tumors in relation to the immune system a little bit more warm, and make these therapies more effective.
Okay, well, I will answer and say for us, I think the exciting thing is more personalized approaches to immunotherapy, because at the moment the FDA approved therapies we're using, such as anti-PD-1 and PD-1 plus LAG-3, pretty much every patient is having the same thing, but we know that each cancer will express very unique antigens, and so we're actually undertaking projects at the moment to actually identify and target unique antigens on a patient's tumor, and we feel this might be a more effective and personalized way of being able to treat melanoma in future.
Awesome. And when you have melanoma, what other cancers are you at increased risk for? So, some other cancers are a little bit more genetic driven as far as genetic predispositions, such as breast cancer, the BRCA genes, and things like that. With melanoma, most of our patients develop this in a sporadic nature. Certainly, there are genetic predispositions, and patients with lighter skin are more likely to develop a skin cancer, and then the environmental factors play the significant factor here for the more common subtypes, such as UV-induced melanomas. Either sunlight, tanning beds are a big factor. So the most common skin cancers that you're at increased risk for if you develop a melanoma that is UV-induced would be other skin cancers, such as squamous cell carcinoma of the skin, basal cell carcinoma of the skin, and as one of my mentors and boss, Dr. Sondak, has always said, the sun didn't only shine in one place. And so, when patients develop a skin cancer, they're at increased risk to develop another separate skin cancer somewhere else in the body, on the skin. And so that's what we discuss with our patients and counsel them. There is some genetic conditions that link melanoma with like pancreas cancer and things like that, but these are very rare and typically not what we would expect when we see a patient come to our office with melanoma. Can the patient identify, or can the pathologist identify an acral melanoma without knowing its site of origin? Are there specific histologic features? That's a great question. So yes, they can actually see, we call it acral lentiginous melanoma. There's a specific pattern, histologic pattern that these have, and a lentiginous pattern. And so that can help, determine the difference between whether these are really truly acral lentiginous melanoma or just a sun-induced melanoma that happens to be on the hand or the foot. Next, can you have a similar meeting talking about the less rare types that still have extreme metastasis and are participating in your trials? Because you have only talked about such a rare melanoma. Can you offer us a little more general session, helping us see how and when you get the 5-year survival rate from 35% to, let's hope, 75%? How close are you now? Well, certainly we can, plan something in the future where we can do more of a, focus on the conventional melanoma and advanced melanoma for the conventional subtypes. Absolutely. Next question. When would doctors order Castle testing? Is this what was used in the Merlin study? So this was a different genetic test. The Castle test is Dr. Smalley, do you have, just to kind of keep you included here with some of these questions, do you have good background on the Castle genes that are specifically in those? Okay, but the Castle test is a separate set of genetic mutations that they test for in the melanoma. It was, one of the things that Dr. Sondak mentioned about the Merlin study and that unique test is that this was the first truly prospective, trial, large prospective trial that looked at, gene expression profiling in melanoma. And the Castle test does also have now a clinical aspect to it where it looks at not only the gene signature of the melanoma, but also the clinical picture of the melanoma, and the clinical factors, which is what the Merlin Skyline study did as well. And so they're both genetic gene expression profiling tests for melanoma and to assess for the risk of metastasis from melanoma. But the Merlin test has been a little bit more recently kind of vigorously studied in the larger and prospective clinical trial space. We do not routinely use Castle testing. We have not really seen any benefit to Castle testing that proves that it kind of changes your opinion on what you'll do for a patient over just the clinical factors, the clinical pathologic factors such as Breslow depth, and some of the other histologic features that we see on the biopsy reports. So we do not routinely, usually get those tests. Some of our patients will come in with those tests already done by the dermatologist, but if the patient kind of already meets criteria for sentinel lymph node biopsy, we do not have enough evidence here at Moffitt to say, well, then because of that Castle test, we'll not do the sentinel lymph node biopsy or vice versa. Next question. I was part of the Merlin study. Is it possible for me to find out the results of my individual genetic analysis? We can answer that question for you. We may have to get back to you on that. I don't know if I don't believe they were going to be releasing personal data like that. But I'd have to, in order to not tell you something wrong, I'd either have to have Dr. Sondak chime in or have to get back to you on that.
The short answer is no. The company had no idea whose specimen they were getting. That was the condition. It was all totally anonymous, and we don't know, which person that we operated on was positive or negative. It's only a group analysis. So that's the downside of a blinded study, is we do not know what was what. And one of the reasons why it's still blinded is that we're going to continue to analyze the outcomes and see if maybe you were high risk, but your sentinel node was negative. Maybe you've got a higher risk for melanoma coming back, and we can learn something about those individual genes. So we haven't stopped. I didn't talk about that second phase of the study because that's still years away from completion. But again, that's the downside of a blinded study, but it makes the scientific quality of the information and the immediate usefulness of it much, much greater.
Well, it seems that we've come to the closing here, and I just want to thank all of our panelists, first and foremost, for sharing everything with us today. But thank you, everyone, for attending. Should you have any more questions, feel free to reach out and be glad to direct your questions any which way. But thank you for joining us this evening, and have a wonderful evening.